Health financing as an enabler for primary health care orientation. The Experience of Brazil, a presentation made by Dr. Adelson Guaraciante, a Brazilian family physician, researcher, and a consultant for health system strengthening. When we talk about primary health care, the first image that comes to mind is something like the pictures you can see here. A health post or a community health center near the neighborhood where people live. A place where patients can seek a variety of health services and make first contact with the health system. It can also be something like a boat, a fluvial health unit, very common in Brazil, Amazon region, or even a telemedicine service, which has become increasingly popular in Brazil and many other places around the world. From an academic perspective, the concept primary care brings us to the work of Barbara Starfield, who helped organize the concept known for the 5 C's or the essential attributes of primary care, being the first point of contact for healthcare, providing comprehensive care rather than just a one off encounter, coordinating the patient's care with the local team, with their families and caregivers, and with all levels of care according to each person's need, ensuring continuity of care and also ensuring that the care provided meets each person's health needs. This concept is further elaborated by the World Health Organization and UNICEF. They present us a broader understanding of what taking care of people's health needs mean, the primary healthcare approach, a whole of society approach to health that aims to maximize the level and distribution of health and well-being through three components. In blue, we have multi-sectoral policy and actions. In orange, empowered people and communities. And at the base of the triangle in yellow, integrated health services with a strong emphasis on primary care and on essential public health functions. As detailed in the 2020 operational framework for primary health care, transforming vision into action, the primary care approach comprises three components and relies on 14 levers that must be pulled to ensure high quality and effective care. In that document, we see how these three domains connect vision, action, and outcomes. The expected outcomes are improved access, utilization, and quality, improved participation, health literacy, and care seeking, and improved determinants of health, moving toward universal health coverage and the Sustainable Development Goals. These 14 levers are grouped into four strategic ones, being political commitment and leadership, governance and policy frameworks, financing and resource allocation, and community and stakeholder engagement, the four strategic ones. And then 10 operational levers, models of care, health workforce, physical infrastructure, medicines and supplies, engagement with the private sector, purchasing and provider payment methods, digital technologies, systems to improve quality of care, primary care oriented research, and finally, monitoring and evaluation. Why then talk about Brazil when we talk about primary health care? And the reason is quite simple. Since 1994, Brazil has stood out for having managed over its history to activate these 14 policy levers through a series of reforms. Over the past 31 years, the country has achieved striking results, reducing infant mortality, reducing maternal mortality, providing better care for non communicable chronic conditions, and lowering mortality and hospitalizations due to chronic diseases and fewer avoidable hospital admissions. Many of these results are documented in a series of articles, some of which are shown here on this slide. So, where should we start to tell this story? The best place is precisely that image from the beginning. A team of healthcare professionals working in a clinic in the community, taking care of the people who live in the neighborhood. In 1994, Brazil's national primary care policy was established under the name Family Health Strategy, or Estratégia de Saúde da Família. The Family Health Strategy defined the family health team as the model for provision of primary care services. The model of care corresponds to the fifth WHO level. By model of care, we mean what are the ingredients that we put together into the local community health unit? How do we combine those ingredients to deliver the care that the people living in that community needs? A useful framework for understanding models of care was proposed in 2018 by Asaf Baiton and colleagues. It is called the 5S, 5M, 5C. It lays out the 5S, or the five ingredients, the 5M, or the five process elements that combine those ingredients, and the 5C, or the five results we expect from high quality primary care. Regarding the 5S, or the five ingredients and structure domains, we have space, the physical setting, systems, information systems like paper or electronic medical records. We have the staff, the people who works there, how many professionals, which professions and their level of training and qualification. We have stuffs, medicines, equipment, supplies available to do the work, and surveillance for communicable or non-communicable diseases, for clinical work, and for public health. These five ingredients are combined through 5M, or five process domains that are crucial to organization. Multidisciplinary work, so no one works in isolation or makes decision alone. Metrics for results, performance, and outcomes. Monitoring over time using time series to follow the metrics. Motivation, meaning strategies for continuous quality improvement. And management, both of the local unit at the regional levels, the municipal health districts, as well as populational management. And by organizing the five ingredients through five process elements, we aim to achieve the five C's, or the five results of high quality primary care. First contact, continuity, coordination, comprehensiveness, and patient centered care. Under the Brazil's family health strategy, family health teams became the new model of care. A typical team includes one physician, one nurse technician, and 4 to 6 community health workers. Each team is empaneled to 4,000 people living in a defined catchment area and works 40 hours per week on a salary based contract. The family health team integrates health services by combining public health actions such as vaccination, screening for chronic diseases and cancer, health surveillance, and health promotion and prevention, with clinical care tailored to patients' needs, like detecting and managing both acute and chronic conditions, providing rehabilitation and palliative care when needed. Under Brazil's family health strategy, a key change was empanelment, which means formally assigning patients to a specific primary care team. Before 1994, no provider was responsible for a defined group. The new model of care fixes that. In Brazil, empanelment is based on place of residence. Each neighborhood belongs to a catchment area served by one family health team. And in the illustration, you can see four areas, each covered by a different team. Residents of the yellow area, for example, are assigned to the yellow family health team. And patients know who their doctor, nurse, and community health workers are. Because panels are defined, the team also knows exactly who their patients are. Appointments are scheduled on that team's agenda, allowing the team members to share responsibilities and see different patients at the same time. Beyond the new model of care, another crucial change in 1994 was the decentralization. Now, municipalities became responsible for delivering primary care, for hiring professionals, organizing infrastructure, purchasing services and supplies, managing the day to day work of family health teams, and measuring performance and metrics. With the family health strategy and its new model of care, Brazil shifted from selective primary care toward a more comprehensive primary care. In other words, moved from a vertical and narrow set of services and programs, for example, growth monitoring, birth control, tuberculosis, and vaccination, to a broader range of care, including health promotion, preventive measures, chronic disease management, rehabilitation, and palliative care. So, what is the difference between selective and comprehensive primary care? Under selective primary care, needs are fragmented, and so is the family's care. The mother receives prenatal and family planning services from one worker. The young daughter gets growth monitoring and immunization from another worker. The son with diarrhea receives oral hydration in a one off visit, and the father with tuberculosis is seen by a TB specialist. And the grandmother may or may not access care for common conditions like hypertension or diabetes, depending on the availability of those services. Each problem is managed separately, often by a different professional in different rooms. And most of the time, those workers do not know what their colleagues are doing or which patients and families they are seeing. In Brazil, by contrast, build a model where empowerment is explicit. Teams know their patients, and patients know their team. Empowerment organizes access and makes primary care the front door, gatekeeping function. So problems enter the health system there rather than directly in hospitals or other medical specialties. Because each family health team is accountable for 1,000 residents, comprehensiveness isn't optional. And the same team provides ongoing care, coordinates referral, and ensures continuity across levels whenever needed. So, how did Brazil orient its health system toward primary care? Well, Brazil is a federal presidential republic with 26 states and one federal district. It is the world's fifth largest country by area and the sixth most populous one. A key detail: Brazil has 2.8 physicians per 1,000 inhabitants, and this is a critical determinant of the scale and functioning of its current primary care model. Brazil is also a country of deep social and regional inequalities, still a very unequal country. And over the past 80 years, life expectancy has risen and infant mortality has fallen. But these gains were uneven across regions and did not occur overnight or by accident. A major turning point was the 1988 Constitution, which opened the door to decentralizing public systems in health, in education, and social security. In 1990, Brazil created the Unified Health System, enshrining universal health care and putting it into practice. Primary care was central from the start, first with the community health workers in 1991 and then with the family health strategy in 1994. When reforms made primary care more complex in structure, financing, and its scope. In 1998, Brazil passed its first law organizing primary care financing system, later expanded in 2008. In 2011, it introduced the first national pay for performance program, and in 2013, it launched the first national initiative to fix the uneven distribution of doctors across the country, the More Doctors program. Today, primary care in Brazil has a very complex financing model, reflecting the changes and evolutions that happened over those years. Here's a picture from the 8th National Health Conference capturing the inception of the Brazilian national health system. The national health system represented a shift from a Bismarckian model, where access depended on formal employment, to a Beveridgean model of universal rights. Financing moved to federal, state, and municipal taxes. Coverage became universal and free at the point of care, regardless of employment status, formal, informal, or unemployed. The system is public organized from financing to purchase and provision, while also contracting private providers. This trajectory reflects activation of the four strategic levers: political commitment and leadership, governance and policy frameworks, financing and resource allocation, and social participation. When that happened, one of the three pillars for the primary healthcare approach was organized, allowing social participation and making people and communities key stakeholders in the national health system decision making process. Organizations such as councils of states and municipal health secretaries, universities, research centers, public health institutes, and civil society organizations such as the Brazilian Society of Family Medicine and Brazilian Society of Community Nursing, all contributing to a more democratic health system design. How is the Brazilian health system financed? This overview addresses the entire system, not just primary care, but it is essential to understand how primary care is later financed. Revenue collection is primarily through federal, state, and municipal taxes. Public spending is mandatory at each level, ensuring continuous resource allocation. Municipalities must spend 15% of their budget on health, states 12%, and the federal government must spend at least what was spent in the previous year, adjusted nominally by GDP growth. These funds are pooled and organized through health funds at each level, municipal, state, and national level, with specific transfers among them. This decentralized model promotes equity, though it also adds complexity to resource distribution coordination. Purchasing occurs mostly within the public system. Historically, allocations have been based on past funding levels and population size, with performance indicators playing a growing role in recent years. At the municipal level, there are five tiers and five specific health functions: primary care, secondary and tertiary care, pharmaceuticals, health surveillance, and management, each receiving specific allocation of funds. Here we can see the flow chart of the Brazilian financing health system, presenting revenue collection, pooling of funds among the national, state, and municipal funds, leading to several types of functions and service purchase. Since 1990, Brazil's health spending has risen from 6.7% of GDP to 9.5% in 2018. Today, total expenditure is roughly 42% public and 58% private, with about 27% out of pocket and 29% via private insurance. Finally, how is the family health strategy financed? Innovative financing arrangements during Brazil's 1990s health reforms created a sustainable base for scaling the family health strategy. The primary care financing mechanism, the primary care funding floor, was established in 1996 and implemented in 1998, combining a fixed component tied to municipal population with a variable component linked to federal priorities. Through the primary care funding floor, regular automatic monthly transfer flowed from the federal government to municipalities, enabling them to organize and operate their private primary care systems. Over time, primary care funding floor was refined to encourage municipal adoption of the family health strategy, broaden service scope, and reduce health inequalities. Between 1998 and 2019, the fixed plus variable floor remained the central financing role. The fixed floor was a per capita transfer from the National Health Fund to the municipal health funds, ensuring a stable monthly flow based on each municipality's estimated population. In 2019, this fixed transfer ranged from 24 to 28 Brazilian reais, roughly 5 to 7 dollars per capita per year. Larger municipalities and those with fully integrated primary care received the full amount. The variable floor functioned as an incentive to create and sustain family health teams. Municipalities received additional funding for each registered active team, calculated from the validated team count in the national database. This transfer typically ranged from 11,000 to 14,000 Brazilian reais per month, roughly $2,000 to $3,000 every month, varying by team characteristics and regional needs. Teams without a physician for more than 3 months lost eligibility for the variable component. Transfer were released after federal validation of each new team's implementation. As years passed, both components and their specific variations were adjusted to reflect growing complexity, regional diversity, and differences in the population served, while preserving a core logic. The fixed floor ensured a stable, routine floor of federal resources to municipalities. The variable floor created target incentives for municipalities to engage in the family health strategy and implement new teams. From the year 2000 to 2017, the fixed floor increased from 5.6 billion to 6.8 billion Brazilian reais. Over the same period, the variable floor quintupled, rising from 2.6 billion to 10.4 billion Brazilian reais in 2017, a clear evidence of a strong federal push for municipalities to adopt and expand the family health strategy and to create new family health teams. As a result, since 1998, the number of family health teams in Brazil has grown exponentially, from fewer than 5,000 in the beginning to roughly 45,000 teams by 2020. Increased federal to municipal transfer not only expanded primary care funding, but it stimulated even greater municipal co-investment. In the time series, the dark line shows federal transfer rising steadily. Meanwhile, municipal owned source spending on primary care climbs even faster. Clear evidence that federal incentives crowded in local investment to strengthen municipal primary care. Through the primary care funding floor, with a combination of a fixed per capita floor plus a variable team based incentive, Brazil created a stable monthly transfer and targeted rewards to expand and sustain family health teams. This financing design activated the marked levers strategically, governance and policy frameworks, and finance and resource allocation, and operationally, models of care, primary healthcare workforce, purchase and payment systems tied to team validation and performance. The result? Align money, rules, and incentives that scale primary care. In 2008, Brazil created the Expanded Multidisciplinary Teams, or NASF in Portuguese, designed to support the original family health teams and help them expand their scope of practice. Each NASF typically supports 5 to 9 family health teams and may include psychologists, social workers, pharmacists, nutritionists, physiotherapists, occupational therapists, physical education professionals, and speech therapists. They also receive federal incentives. In this way, Lever 6 workforce and Lever 10 purchasing and payment systems are activated to improve primary care. In 2013, the More Doctors program was established to tackle shortage of doctors in remote and underserved areas, a common challenge in a country the size of Brazil. This policy further reinforced Lever 6, the workforce. In 2011, Brazil launched its first national pay for performance program for primary care, called Program for Improving Access and Quality, PEMAC. With PEMAC, several levers were activated simultaneously: governance and policy frameworks, financing and resource allocation, and also the operational levers of models of care, workforce, physical infrastructure, purchasing and payment, and systems for improving quality of care. Currently, Brazil is facing the third wave of payment for performance schemes. Also, in 2013, the federal government launched the Electronic Primary Care Record System, ESUS, allowing all municipalities have an electronic health record system available for all family health teams to record primary care activities and procedures electronically. This initiative further activated digital technologies for health and quality improvement systems. Earlier in 2003, the National Pharmaceutical Policy had established a national essential list of medicines, guaranteeing essential medicines and supplies at the primary care level for Brazil's most prevalent health problems, thus advancing the medicines and other health products level. And in the early 2000s, the Civil Society Organization Regulatory Act enabled social organizations for health and public-private partnerships, allowing municipalities to contract nonprofit operators to manage public facilities under performance-based contracts. The result? Greater efficiency across hospitals, primary care, labs, and telemedicine, stronger oversight and accountability, and a streamlined procurement. This reform activated levers engagement with private sector providers and purchasing and payment systems. We have already covered two of the three primary healthcare components of the primary healthcare approach from the WHO. First, the orange pillar empower people and communities, showing how social participation shapes political decision making in Brazil. Second, the yellow base, integrated health services, tracing how since 1994 a series of policies build patient-centered primary care with strong links to essential public health functions. Within this framework, the family health strategy created the finance and governance architecture that makes municipalities responsible for primary care delivery through family health teams, organizing empowerment, access, continuity, comprehensiveness, and patient-centered care. The final component of the primary healthcare approach to mention here is the domain of multi-sectoral policies and actions, which systematically address the social determinants of health, including socioeconomic and environmental factors, as well as individuals' characteristics and behaviors. In Brazil, this pillar is exemplified by the Bolsa Família program, a conditional cash transfer program where families living in poverty receive financial support if they meet key conditions. Children aged 6 to 17 years old must attend school regularly, and families must take them to primary care for immunizations and growth monitoring and nutritional follow up. Over the years, the Bolsa Familia program has been highly effective, advancing multiple sustainable development goals at once, promoting health and well being, reducing maternal mortality, preventing avoidable child and neonatal deaths, combating epidemics, lowering premature mortality from non communicable diseases, and ensuring universal access to sexual and reproductive health services. The impact of this program not only reflects the direct effect of the cash transfer, but the synergy between the Bolsa Familia program and primary care policies such as the family health strategy. Together, these policies are associated with sharp reductions in hospitalizations and deaths, including large declines in under 5 mortality and substantial drops in hospitalization among the elderly. The lesson is clear. Integrated services anchored in strong primary care, combined with multi-sectoral policies and active community engagement, they improve both the quality of care and the quality of life. So, what are the current issues primary health care is facing in Brazil? First is the battle between performance indicators versus quality improvement. Family health teams are doing their best to care for their patients, and simply adding targets and performance indicators does not necessarily make their work easier or more efficient. There's also the big question that is still open to an answer. Is primary care in Brazil in the driver's seat already? The answer will be a yes and no. So the family health strategy delivers person-centered care and public health actions. Yet the integration with higher levels of care remains uneven, especially when it comes to actionable intelligence for network-wide planning. Strengthening primary care oriented research, the level 13, and monitoring and evaluation, the level 14, they are essential. Not as punitive scorecards, but as learning systems that feed improvement at the front line. And also, Brazil's highly unequal conditions translate into stark differences in human resources, hiring models, salaries, practices, and primary care infrastructure across municipalities. Physician distribution is particularly uneven in the country. About one doctor per 3,000 people in small towns versus one per 230 in large cities. Addressing these gaps requires a smarter resource allocation, municipal management support, and better data flows between the levels of care. So primary care can truly steer the system while continuously improving quality. Despite the current challenges, in summary, we can say that it was a combined force of the WHO's four strategic levers, together with the 10 operational levers that guarantee primary healthcare implementation in Brazil. And special attention goes to financing and resource allocation. Without integrating financial incentives with the other 13 levers, the results will not have been achievable. Equally important was the synergy among policies pulling those levers, not merely allocating more money, but allocating it wisely, building strong governance, aligning payment and accountability, and sharing responsibility across the federal, state, and municipal levels. This integrated approach defined roles, enforced spending floors, routed funds through intergovernmental health pooling funds, and enabled a sustainable shift from selective to comprehensive primary health care, delivering significant population health gains. Muito obrigado. Thank you very much.
Free audio post production by alphonic.com.